Good morning to everybody, and thank you for being here. My presentation will be in the name of all the Harmonization for Health in Africa, HHA. As you know, this is a consortium of partners who works in Africa for the entire region and is really dedicated to support health systems and health financing to deliver results on health outcomes, and particularly for the poor. And in the name of HHA, again, welcome here. It's my responsibility to sort of introduce Africa's health in this session before we hear from Professor Julio Frank talking about global experience and about Hans Rosling, who will get us very much in depth into data. But what is it that brings us today here in Tunis, Tunisia, that is new about Africa? First thing is, how does this work? Yeah, it doesn't work. Okay. We're talking right now about no less than Africa's metamorphosis. Africa now is a continent of rapid economic growth. As Dr. Kaberuka said this morning, 5 to 8% per annum, probably 6, 7 this year. And last year, 6 out of the 10 world's fastest growing economies were in Africa. However, growth is not always inclusive. What we see also, it's also 6 out of the 10 most unequal countries are now in sub-Saharan Africa, and particularly Southern Africa, with Namibia being the most inequitable country in the world. Poor people have also in Africa much less access to health care than the richer groups of Africa. What is new also is the new opportunity for Africa to reap the demographic dividend. Africa has 1 billion people today. It will have 2.3 billion people by 2050. It's the most populous continent after Asia and the youngest region in the world. In fact, by 2040, it will have the largest workforce, surpassing China and India. Is this going to be an incredible asset of young, productive, healthy, educated people, or is it going to be a potential risk and a potential factor of social unrest? What we see is these young people, and this is why it is so important for us to meet in Tunisia. These young people are driving change. There are profound political shifts driven by these new demographics. Less conflict and more demand for voice and accountability, as illustrated in the Tunisia revolution. A decade ago, the global community has committed to the MDGs. Are the MDGs a success? And what's next? In fact, most of us in this room and outside this room were very pessimistic about Africa reaching the MDGs. Yet, Africa has done some of the fastest progress ever observed historically in improving health outcomes, particularly child mortality, fertility, but also control of malaria and HIV. And we see now some of these countries like Senegal, Rwanda, Kenya, Uganda, Ghana, reaping now the beginning of the demographic dividend, changing profoundly the structure of their population. Yet, there is still a lot to do. In fact, most goals will not be met by Africa overall. Maybe Africa was set to fail because those goals were too ambitious. As we see, Africa has reached progress in a historical way that has never been observed before, but still it was not fast enough to reach the MDGs. There are also some countries who significantly counterperformed. And what is most important is today, none of the fragile states is likely to reach any of the MDGs, again calling to work on the issue of social cohesion and addressing the potential social unrest. There are still major issues to be addressed. First, yes, there is economic growth, but there is very low growth elasticity of poverty. Poverty is not declining fast enough. There are very high inequalities in distribution of assets and access to service, making health profoundly a governance problem. And quality of services is still very low. The MDGs remain, therefore, for the next 3 years, still mostly an Africa agenda. Poverty declined only by 0.5%, much less than East Asia and South Asia. And Africa, who only accounts for only 12% of the world's population, accounts for most of maternal deaths, child deaths, malaria cases, HIV, and a large part of malnutrition. But health financing in Africa is also changing. Health spending in SSA has more than doubled since 1995. But SSA still has a low per capita spending on health. Yet, the low per capita spending on health in Africa is actually higher than what South Asia spends. Yet, South Asian countries are doing much better in terms of health outcomes and reaching the MDGs. So yes, there is a money issue, but there is also an issue of more value for the money and better health for the money. One particular feature when we see this increase in spending in Africa is that there are very high levels of private spending. A large part of that increase in spending is actually linked to people paying out of pocket to pay for healthcare and to pay for private providers. More than half of the spending in Africa today is done through the private sector. A new emerging story also is the profound change of ODA, both in the way ODA amounts evolve as well as the way it is delivered. It is a mixed picture, and the question is whether it is starting to decline. What we know for sure is a recent report of the European Union announced that between 2009 and 10, ODA declined from 15 billion about to 10 billion. Another question is whether the ODA that is supposed to be allocated for health always goes to health. We know that ODA for health, in red here, has peaked around 2010. But what we increasingly observe, and has been documented by several studies, and there is a large level of fungibility, of crowding out. Yes, external money comes to pay for health, but very often it displaces domestic money. And some data show that for every $1 of development assistance for health channeled through governments on average took 0.4 to 1.1 away from the health sector. So sometimes earmarking money for the health sector leads actually to less money for the health sector. The issue of value for money and more health for the money is also the issue of improving efficiency. A recent World Health Organization report shows that between 20 and 40% of health system spending is wasted, and poorer countries waste even higher proportion. Those countries that are often aided by donors or donor-dependent. For each $1 spent on health, less than 30% often doesn't reach the front line, according to the public expenditure tracking surveys supported by the World Bank. And absenteeism can affect sometimes up to 40% of health workers in some African countries. So when we talk about investing in health for Africa, what does the evidence say? First, focus on high-impact interventions, getting bang for the buck. And here are, for example, 8 key health interventions that are shown scientifically and at country level to buy large amounts of decline in child mortality, in maternal mortality, and other health indicators. Birth spacing, family planning, antenatal care, avoiding HIV to pass from mother to children, helping mothers to deliver at birth and providing them postnatal care, exclusive breastfeedings for 6 months, immunization, treatment, antibiotic treatment for pneumonia, and of course in Africa, the incredible impact of insecticide-treated nets, and a recent World Bank study attributing up to 50% of the decline of mortality in Kenya to the use of bed nets. Yet, we know we have these high-impact interventions, but this is not necessarily where the money goes, and this is not necessarily where the domestic budgets are allocated towards. And when we see the level of coverage for these high-impact interventions here in both West and East Africa, they're still very low. Yet, lesson 2, we know that progress can be achieved within a short time period. 2 examples here. Ethiopia, training, deploying, hiring, remunerating more than 40,000 health workers over a period of 3 years. And associated to that, a dramatic increase in the use of bed nets and spectacular impact on decreasing mortality due to malaria. Rwanda, one of the fastest increased in assisted birth deliveries for pregnant women, from less than 30% to 70% in less than 5 years. African countries can deliver, and they can deliver fast. They can also deliver on mitigating the impoverishing effect of disease, as highlighted by Dr. Chan. In Rwanda, about 30 to 35 uninsured households incur catastrophic expenditures, much more than those who were insured. In Ghana, the health insurance enrollment reduced out-of-pocket spending by more than 80% and protects against catastrophic expenditures. And finally, the lesson from the Arab Spring, the message to the world given to us by the Prime Minister of Tunisia. Power to the people helps, and science proves it. And here's a study done in Uganda using community scorecards. And when community scorecards are introduced, giving the power to citizens and African populations to monitor service providers, we see results. Higher utilization of services, lower deaths among children, more deliveries in the facilities, shorter wait time, and less absenteeism. So the question that we will need to respond to over the next two days is how can we expand and deepen these successes? Can finance and health speak the same language? It's like a couple. Women come from Venus, and men come from Mars. I don't know whether finance is Venus or Mars. But can we speak the same language? Thank you very much.